Hi, I'm Dr. Kamioka from Tokai University Hospital in Japan. Thank you for the opportunity to give a talk at this new, exciting, excellent conference here. The topic I was assigned today is consideration and management of PVL after TMVR. PVL after TMVR, which mechanism varies depending on the type of TMVR. You can do TMVR with a transcatheter head valve not designed for mitral position, meaning valve expandable valve such as SAPIEN 3 valve or MAPL valve. Or you can do TMVR with a dedicated transcatheter head valve such as 10-9 valve or interfit valve or something else. And in this presentation, I will discuss PVL after TMVR with valve expandable valve SAPIEN 3 valve. And I'm trying to show the mechanism of PVL after TMVR, valve-in-valve, and valve-in-ring, and valve-in-MAC procedure. So the first one is TMVR valve-in-valve with a SAPIEN 3 valve. This procedure is mostly straightforward because you can put circular valve in cylindrical long landing zone. So you have minimal risk of PVL, and usually the valve is self-centered. And even if you have PVL beforehand, you may oversize the valve, and then you may eliminate PVL after the procedure. And this is a data from one of the biggest data, registry data, and showing outcomes and frequency of PVL after TMVL in valve-in-valve, valve-in-ring, or valve-in-MAC. And based on this report, valve-in-ring or valve-in-MAC procedure is more challenging. And let me see, this is conversion to surgery rate is highest in valve-in-MAC procedure, and valve embolization is also highest in valve-in-MAC procedure. And the rate of need for second valve is highest in high valve-in-ring procedure, even though valve-in-ring procedure had PVL closure procedure afterwards. So, and overall device success rate is 69.5% after valve-in-ring procedure and 53.4% after valve-in-MAC procedure. Looks like these data suggest valve-in-ring or valve-in-MAC procedure is more challenging, and there is different kind of issue in the procedure itself. And MR, assuming this is mostly PVL, and MR, more than mild MR after the procedure is observed in 18.4% after valve-in-ring procedure and 13.8% after valve-in-MAC procedure. However, after this PVL intervention, more than mild MR was observed in 12.6% in valve-in-ring procedure and 13.2% in valve-in-MAC procedure. So the next question is, what makes this valve-in-ring procedure or valve-in-MAC procedure challenging, meaning higher risk of PVL? What's different from valve-in-MAC procedure? One issue is landing zone issue. As you can see, the ring has only 2 or 3 millimeter metal part here, meaning it's very short landing zone. And usually, especially valve-in-MAC patient, has sharp aortic mitral angle. That is another part of landing zone issue. And also, as we all know, there is a risk of LVOT obstruction after TMVR, valve-in-ring or valve-in-MAC procedure. Speaking of unfavorable ring or band for TMVR bobbin ring, let me introduce a couple of bands we cannot use for bobbin ring procedure. These are incomplete flexible bands, coastal band, Duran Anchor, Similas, or Semi-plus flexible band. These bands have a very soft part here, and there's no anterior support, so you shouldn't do TMVL bobbin ring procedure because high risk for embolization. Actually, this is not for PVL. Risk for PVL, but this ring has a higher PVL risk, and this is complete rigid ring, and Edwards Life Science, made by Edwards Life Science, and geoform ring. This ring has very short AP and SL distance with rigid ring, meaning this ring reaches the extreme deformation of THV and PVL. If you don't overexpand like this, you have PVL from here or here, and if you overexpand like this, you may have smaller PVL, but your valve function is not great. Actually, we performed an experiment like this. We try to expand the geoform ring to see if we can crack the ring like this, but actually the true balloon ruptured, but no impact on the ring here. So I would suggest you don't use this ring for bobbin ring procedure. And there are a couple of other rings unfavorable for TMVR bobbin ring. These are also complete rigid ring, rigid saddle, or IMR etiologics, or Mixel, or Profile 3D. These rings can be used for TMVR bobbin ring, depends on the size of the ring, but as you can see like this, you may have PVL from this gap between the ring and the valve here. And like geoform ring, you can minimize the PVL risk, but you have worse valve function like this after bobbin ring procedure. So these are also concerning rings for bobbin ring procedure. So in addition to landing zone issue and risk of alveolar obstruction, another thing makes TMVR by MAC challenging. That is uncertainty of MAC behavior. Each patient has different MAC, so you cannot exactly estimate risk of PVL and hemolysis. So, and this is variation of MAC. The center one is well-distributed MAC and looks very rigid MAC, and the commissural distance is 30.9, which may be covered by overexpanded Sapien 329 mm valve, and you'll have minimal risk of PVL because this part is almost circular, or you may call it oval, but either way, you'll have minimal risk of PVL. And the left one is what we call Casier's MAC. And this looks like almost light stone, which means it's very soft, and it's your valve may compress this Casier's MAC, and So in that sense, the sealing may occur multiple points, or you may have, it's small PVL afterwards, but you don't know if the valve have enough force to anchor the valve. On the other hand, this right one is a non-homogeneous MAC. So if you put virtual valve like this, you can put the valve, probably you can put the valve like this, and this MAC can hold the valve and anchor the valve. But as you can see here, you may have a gap between the valve and MAC here. At the same time, you don't know which part makes sealing between MAC and valve. So at this point, you don't know how much PVL may occur beforehand. So this is a summary for consideration of PVL in valve and ring or valve and MAC procedure. For valve and ring procedure, you need to know ring geometry and dimension for sizing, and you need to know ring compliance, as I showed, flexible or rigid or semi compliant, or ring suitability for anchoring. These are very important. And for valve and MAC procedure, 3D MAC distribution and dimension for valve sizing and sealing, because that is critical for estimating PVL. And you need to know, you need to estimate MAC compliance and suitability for valve anchoring as well. Another thing I want to emphasize is importance of co-axiality. Usually, when you put the valve valve in ring or MAC, your valve, the angle of your valve follows towards the apex of the left ventricle, and if this annular to apex angle is two counting, you'll have the PVL from this gap between outer skirt part and ring here. We all know inner skirt is 11.6 millimeter for 29 millimeter valve, but outer skirt is 8.1 millimeter. So you have 3 millimeter smaller skirt height for 29 millimeter valve, and 26 millimeter valve also has 3 millimeters smaller skirt height for outer skirt. So you need to consider that part as well. So we checked this annular-to-apical angle, and we called it Emory angle, and that is defined by this valve distance and valve skirt height like this. And if your valve is two counting like this, meaning your annular angle is two counting like this, you have higher risk of PVL. And if your valve is two counting like this, you can put the LV apex rail like this, and you may fix your valve angle like this. Usually maximum Emory angle with minimal risk of PVL is 15 degrees. And when we checked the angle of the valve like this, and before we noticed this fact, when the valve angle exceed this 15 degrees, you have a higher risk of higher percentage of PVL like this. But after we noticed this fact, and we corrected we corrected the angle couple case, and we had a smaller percentage of PVL after the procedure. But in some case, we all know we can't have good coaxial angle. And in that case, at Emory, we did a couple of additional procedure like this. So this is type 3 valve, and this is type ultra valve. Ultra valve has the same height, the same skirt height for outer skirt and inner skirt. So we try to mimic this, the same height level like this, and we put the material outer side and above outer skirt here like this, and elongate the landing zone like this. So in this additional feature maneuver, we had smaller risk of PVL like this. So in summary, we need to know a couple things by pre-procedural CT to prevent PVL. So of course, we need to know, we need to estimate if the valve can be anchored in this ring or MAC. And then after that, we need to know, we need to check if the MAC or ring, after the MAC procedure or MAC ring procedure, there can be PVL or not. So for that part, we need to check adequate size or shape to deploy a circular valve, or we need to check enough calcium to anchor valve, or where the sealing occurs after the valving MAC or valving ring procedure. And also, we need to know the valve can be deployed coaxially, meaning annular-to-apical angle is small enough to have minimal risk to mitigate the risk of PVL. But if you still have PVL, you need to invest in mechanism first. And if no central MR present, you may just post-dilate, and then you can eliminate the PVL after the procedure, or if you have a commissural gap, you can put PVL closure device such as AVP2 or ADO2, depends on which country you are in. And if your valve is placed to atrial, you need to know, you need to put the valve to veil out this condition. But if you put valve, of course, the risk of alveolar obstruction increase. So in that sense, you need to check that part as well. But most part, if you put PVL, if you want PVL closure, that the crossing the PVL leak, PVL is really hard because of straightforward PVL line, or if you put PVL device next to the valve, your device may collapse into the inside of the valve and impinge the valve leaflet. So you need to check that part as well. So this is my summary. PVL after TMVR is not uncommon. Pre-procedural CT may help to mitigate risk of PVL, but wouldn't prevent PVL completely. And when it occurs, investigate the mechanism and select the procedure as needed. Thank you.